Hi, everyone. This is Lynn Crawford with the Hope Dementia Support Groups. We are so honored to introduce you to Dr. Barak Gaster. He's a primary care liaison and professor of medicine for the University of Washington's Division of General Internal Medicine. He also works with the Memory and Brain Wellness Clinic, Project Echo Dementia, Alzheimer's Disease Research Center, and he is a key and co-investigator. He's been an educator and primary care physician at U of W since 1998. He's gained a national reputation for creating solutions to difficult problems in medicine. He has more than 15 years of experience as a clinician, a teacher, and an improvement leader at the University of Washington Medicine. He is designing training for primary care providers. His goal is to educate PCPs in how to identify dementia earlier and how to help patients and families navigate this difficult disease. Welcome, Dr. Gaster.
Thank you so much, and it's really such a pleasure to be here. And like Lynn said, I'm a primary care doctor, so I work in a general internal medicine clinic in Seattle and spend a fair amount of my time seeing patients, but then also do, like she said, a fair amount of my time developing programs to help other primary care doctors like myself do a better job of identifying dementia earlier and helping patients and families navigate through the various stages of the disease. And such a big, important part of providing good care for people with dementia is what's called advanced care planning, which is helping to understand better in advance what somebody would want for the goals of their medical care to be in the future. And so that's what I'm going to talk about today. And this is meant to be a pretty informal, I don't mean this to be sort of any kind of a formal lecture, but I do want to really save lots of time at the end for questions. And so for sure, as my talk goes along, feel free to put questions in the chat to be sort of saved and passed along at the end. And I really do look forward to having a good discussion about a lot of this stuff towards the end. So I want to start out a little bit talking about what is unique about dementia, because as I first started working in this area, I had some people push back and say, why is there special advanced care planning for dementia versus, do you need special advanced care planning for emphysema and special advanced care planning for kidney disease? What's special about dementia? And I think the thing that makes dementia so unique, especially when it comes to making plans for the future, is, as you all know, how early in the disease people lose the ability to make decisions about their own care. That relatively early on, it becomes harder and harder for people to really understand a complex medical decision. And so it really falls to other people to make decisions on their behalf, and that they can then live for many, many years needing other people to help make decisions about their care. And that the course of dementia can often be rough, that there can definitely be periods of agitation where the nicest people can sometimes be kind of adversarial, and it can just be, it's just a hard disease to live through and to take care of. And many people really would want a gradual shift away from life-prolonging care and to comfort-oriented care as a dementia illness progresses. But it's hard to know how to make that shift and how to decide when to make that shift. So you are all aware of just, I'm sure, what a giant problem dementia is in our society. So more than 6 million Americans are living with dementia. It's 1 out of 10 people over age 65, and it's 1 out of 3 people over age 85 who are living with dementia. And this has just been such a hard year for all of these people, that the COVID pandemic has hit people over age 85 the absolute hardest, and people with dementia the absolute hardest. And so I know that you have all been feeling this as well. And the crazy thing about statistics like this is that as large a problem as dementia is today, it's really the projections of what is expected to happen in the future that really gives one pause. That the numbers of people living with dementia is expected to increase by 40% in the next 10 years and will even double in the next 20 years. And so if we think that society is having a hard time managing the dementia that we have in our midst right now, it really is a huge problem that's going to be growing down the road. And whenever I talk about that projection, it's always like, how can that be? Where does that come from? And it's really two things that are happening together, that people are living longer than ever before, and there is the aging of the baby boom bubble, which is a really unusual cohort of people that were born between 1945 and 1965. So in the 20 years after World War II, there was a giant bubble of people born in those 20 years that has now been called the baby boom bubble. And the baby boomers today, the oldest of the baby boomers, are just now reaching age 70. So they're just now getting to the age where they are at risk of developing Alzheimer's disease or another form of dementia. And so it's when you project that baby boom generation 12 years from now that you really get this projection of just how much how many more people will be living with dementia in the coming years. So really, I think, especially once we make it through this pandemic, by far, I would say dementia is the #1 disease challenge that we face. And that advanced care planning is just so important to provide good dementia care, that if we can align the medical interventions that people get with the medical care that they would have wanted, there's just no question that is better care. That's such a big part of better dementia care, is really understanding the care that the medical care that somebody would have wanted, and making sure that we can get them that care. And so you might think that standard advance directives, so the living wills that are standard in every state, would help give guidance about this, but it is pretty amazing if you look at what's in a standard advance directive. It really is focused so much on these very, very rare conditions like a permanent coma or a persistent vegetative state. And so really provides almost no guidance about dementia, which is kind of crazy because dementia is the #1 reason that people lose the ability to make decisions about their own care. Part of the reason that it's difficult to elicit those wishes is that dementia is complex. I mean, as you all know, that as dementia goes through its many phases, it changes a lot. And initially, the quality of life of somebody with dementia is actually very, very good and is relatively unchanged from what it was before. But then it does decrease slowly as the disease progresses from mild to moderate to severe stages. And so it really makes sense that most people would want different goals for their medical care along the stages of dementia. You can't just say, well, if I had dementia, this is what I would want, because dementia is so different along its trajectory. And early in the course of dementia, people still are having can have a great life, a great quality of life. And so it's really not at all to say that early in dementia, it's the same as what it's like towards the end of dementia. And here's an interesting study that was done in Boston where they took 200 people who were over age 65 who did not have dementia, and they showed them a video series of examples of what living with dementia was like. And they really tried hard to not sort of paint too gloomy or too rosy a picture of what living with dementia is like, but tried to make it a pretty realistic sort of depiction of what that was like. And of those 200 people, 72% indicated that in that relatively advanced stage of dementia that they were showing in the video, that they would want comfort-oriented care only, that they would not want any life-prolonging care. And yet, across the country, that's not what most people with dementia are getting. And so the question is, how do we help people communicate that this is what they would want their wishes to be? And so it was really to help address that problem that over the past 5 or 6 years, I've developed a dementia-specific advance directive. So trying to solve that problem of the standard advance directive that has almost nothing about dementia in it, how could we develop a dementia-specific advance directive that would really help people to express what their wishes would be if they were to develop worsening dementia? And so started working on this with input from experts in palliative care and neurology and geriatrics, and we tested and refined it in a primary care setting and have made it available for free now on the web, where it's been downloaded more than 140,000 times. The directive is structured in this way, where it gives a brief description about what mild dementia is like, and a brief description about what moderate dementia is like, and a brief description about what severe dementia is like. And then under each of those descriptions, it gives people the same 4 options to choose from as to what they would want the goal for their medical care to be if they were in that stage of dementia. And part of the real work to refine this and get it to be a useful and good document was to make sure that it wasn't just a checklist of what I would or wouldn't want, but really provided some of the why for the care options, that really gives people a sense of why they might choose one option or another at a different stage of dementia. The most important one to think about is the second one, where somebody might say that they would not want CPR, they would not want intubation, being hooked up to a breathing machine, but otherwise they might want some life-prolonging medical intervention. And the reason that somebody might choose that is that it's not necessarily obvious that somebody with dementia already has a pretty fragile brain. And if they were to have a catastrophic event like a cardiac arrest or a respiratory arrest where their heart stopped and they needed CPR, or they weren't able to breathe on their own and they needed to be hooked up to a ventilator, even if they were to survive a resuscitation and catastrophic event like that, it is likely that the condition that they would be in after surviving such an event would be that their brain would be much more severely impaired than it was before an event like that. And so somebody with dementia at a specific stage might say, gee, I might want medical care to keep me alive longer, but if I had a catastrophic event that required CPR or required a mechanical ventilator, then I would not want that, because I would be worried that if I were to survive an event like that, I would be much worse off than I was at the beginning before that event. And so, and in that situation, like a cardiac arrest or a severe respiratory failure, like a severe pneumonia, that I would instead want to be allowed to die peacefully. Another option that's on the form is to specifically avoid going to the ER or going to the hospital. So somebody might still want some medical care to keep them alive longer if it could be given in the place that they were living. But if they continue to worsen, then they would not want to go to an ER or a hospital. And the reason for that is that dementia is a very high risk condition in an emergency room and a hospital. It's very high risk of getting severe delirium, confusion, getting complications from the medications that they are given. Going to an ER or a hospital is a difficult thing for a person with dementia. So somebody might say that if that was the only way that they could get care to be kept alive longer, that they would not want to go to a hospital. And so since this directive has been online and available for free for anybody to download. My email address is actually on the website where the Dementia Directive is available. And I've gotten hundreds and hundreds of emails from people all over the country saying really moving, sort of meaningful things about how much they appreciate it and how much of a difference they feel like it could make for them in the future. And so I really do think of the Dementia Directive as something that can give people real peace of mind for filling it out by giving them some a sense of comfort that they have had a chance to express their wishes. For sure, it can give peace of mind later for families who are less sort of wondering and fraught with indecision about what their loved one would have wanted. But like I said before, I really think of this as a way of getting better care, that when we define the value of care as care which is more aligned with patients' values, I really do think that we can get better care. And so the other question is, like, when is the best time to consider a dementia directive? And I will say that when I was initially developing it, my idea was that the person who it would be the most useful for would be for somebody who is at the very, very beginning stages of cognitive impairment. So at the very early stages of Alzheimer's disease, that you'd think that that would be the most important time to fill out a dementia directive. But my experience has been that it can be very difficult for somebody with even very mild cognitive impairment to fill out a directive like this. So it doesn't mean that you couldn't try, or you shouldn't try to fill it out. But I will say that it is often a hard thing for people to imagine future state of themselves when they have even mild cognitive impairment. And so instead of offering it to people with mild cognitive impairment as sort of my first sort of thought, I've actually started offering to everybody over age 65 before they have cognitive impairment. And instead of getting almost none of them back from my patients who have mild cognitive impairment, I get almost all of them back from my patients who are over age 65 who don't have cognitive impairment. And so I really have shifted my thinking as to what the best time to fill out a dementia directive is, as to really being anyone over age 65 before they have any cognitive impairment. And it's also not to say that you couldn't fill it out before age 65, but it's true that it's extremely, extremely unlikely to develop dementia before age 65. And a directive that you filled out when you were, say, 50 is going to be a lot less useful when you're 70 than one that was filled out when you were 65. And so filling one out over age 65, I really think is the best time to do it. So if we were meeting in person, I would be handing out flyers that had this website on it. But unfortunately, I'm not. I wish I could be out with you all, but instead I'm here with you virtually. But I'm happy to email this flyer, and Lynn can get it out to you if you're interested. But really, the flyer doesn't have very much on it other than this website, which is www.dementia-directive.org. And really, it has been shared and linked to all over the web so much that really, if you just type in the words dementia and advanced directive into Google, this really will be one of the very top things that comes up. And if you put my last name in it, Gaster, Gaster, you will for sure get it as one of the very first things that comes up. So don't feel like you absolutely need to know this exact web address exactly, but if you just remember Dementia Directive, you will be able to find this directive really easily. And like I say, it's available for anybody to download for free.
Dr. Gaster,
yeah,
I will send out a copy to everyone who is attending this webinar.
All right.
So then you don't have to worry.
All right. Good. And all right. Let me just answer this one thing. And so the number one question I get about the Dementia Directive is it legal? Because some people really, really are concerned about whether it's legal or not. And whenever I get asked that question, my answer is actually sort of a broader response, which is that we should, it's really almost sad that living wills or advance directives have become such a document that people think of as being this legal thing, as opposed to a communication guide. You know, it's so much more important to think of them as communication guides rather than legal forms, and you know that they are really there to inform families about what patients' values and preferences were, that you can never really use them as a rigid algorithm. And so they never really should be legally binding, that they're really there to provide guidance for proxies and clinicians as they make decisions. And so one of the things you might notice on the document is that we left off a place to get it witnessed or notarized, which again, some people really kind of worry about a lot as to sort of, does that make it less legal if it hasn't been witnessed or notarized? And my answer, the reason that we left this off is that once you put a place on a document for it to be witnessed or notarized, you will immediately reduce the number of people who complete that form. That barrier to getting to feeling like you have to get it witnessed or notarized is such a procrastination moment where people will just like put it away in their drawer and just never get it done. And so I really think of the risk of conflict from people not having an advance directive is greater than the risk that they might have one which somebody would legally challenge because it hadn't been witnessed or notarized. And so it really felt like a better way to get this out into the world in a helpful way, to not have a place for there to be witness or notary. But that said, I mean, could it be notarized? Absolutely. If somebody is really worried about it being legally challenged, you can take any document that you want and get it notarized. You know, that you can add any proof from a notary that it really was you sort of legally signing a document. But that really you could just attach it to the back of a standard advance directive, and it can be a supplement to your standard advance directive, but it actually would be okay for it to stand alone as well. And so, like I said, this is really a guide to help people express their preferences and to really communicate about them to their loved one. And that it's really important to not feel like people are tied to a rigid algorithm, because dementia is such a complex disease, and the number of scenarios that somebody might face is so hard to exactly imagine every situation that somebody might be in, that it's really important to think of it as a structured way to have a conversation with your loved one, to communicate. And then as an added bonus, there's documentation about that communication. So there is something that a family can look back on later. And so I've talked about how the Dementia Directive that I developed is not, it is oftentimes hard for somebody with early dementia to fill out. And so the question then comes, well, if you do have early dementia, what is the most important form to fill out? What's the most important way to communicate your wishes about your advanced preferences? And there I would point people very, very sort of strongly to a filling out a durable power of attorney form. So that's the form that sets out who your surrogate decision maker would be if you were unable to make decisions for yourself about your own care. And the reason that it's so important to fill that out is that dementia you can live with dementia for a very long time. So for years and years and years, that the person who you might think would just sort of naturally or automatically default to being your decision maker is often your spouse, but there is definitely just a risk that over the 10 or 15 years of a dementia illness, somebody's spouse may not be there for the entire duration of that time. And so identifying who the backup to your sort of natural default person would be is just so important. So especially if somebody has many children, identifying who the of among your children, who would be the person that you would really trust the most to really have that sort of authority. And it's not to say that they couldn't consult the other children for making decisions, but it is helpful to identify in a legal document, and this is very much a legal document that needs to be notarized and signed with a notary, so that it can really be clear who among the children would be the person that you would trust the most. And maybe it's not even your children, maybe it's your best friend, or maybe it's your sister, or maybe it's your brother. And there's just so many permutations beyond just the spouse that it's really important to identify in early dementia who that person would be while you're still able. Because really it's the decisions that are made by that durable power of attorney, so by that surrogate decision maker, that healthcare agent, that is really what's most important. And so it's really in early dementia, filling out this form and putting in the alternates is just so important because of that sort of over 20 years sort of concern that your spouse may not be there to serve in that capacity. If I were to point people to one place for help in having conversations about what are the goals of medical care for somebody with dementia, I would really point to the Conversation Project. So that's a wonderful organization based out of Boston that has a website with lots of wonderful materials available for free. And they specifically have a conversation guide that is specifically sort of designed to have with families who are caring for somebody with dementia. And the number one question that's in that form, or that's in that guide, that I really use a lot in my own practice is the question of, if somebody could look down on themselves now, somebody with dementia who's no longer able to really understand the world around them, if they could look down on themselves now, let's imagine having a conversation with them from before and ask, what would you have wanted if looking down on yourself now, what would you want us to do? And that can be such an important way of guiding your thinking and your planning, because it can be so hard to sort of to separate that away from sort of what do you want, and what we really do want to be doing is trying to give good sort of autonomy to the person with dementia to really imagine what would they have wanted us to do. And there, especially as dementia progresses, the most important form to fill out after a durable power of attorney form is a pulsed document. And so a dementia directive is sort of not really a legal document at all. It's a communication tool. A durable power of attorney document is quite legal in that it does need to be witnessed and notarized, and it really can be sort of given to any healthcare place to identify the person who is the surrogate decision maker. But a pulse form is even a whole different higher level of legality in a way, in that this is a physician order. This is a form that you would fill out with a primary care doctor, say, or other doctor who would be able to have a conversation about what the goals of medical care are. So do they include CPR or not if somebody has a cardiac arrest? Does it include being hooked up to a mechanical ventilator? if somebody developed a severe pneumonia in the future? Or is the preference for medical care rather to focus just on providing comfort and really not at all on prolonging life? And so those are the kinds of preferences that can be not just expressed for the future, but actually put into a medical order document signed by a physician that would still need to be sort of double checked and confirmed if somebody ever were to go to an emergency room or a hospital, but is really designed to be portable, to carry from place to place as somebody, say, were to move from one facility to another, or to have on your refrigerator if 911 is called and medics arrive, that the medics will see a pulse form on a refrigerator, and if it says do not do CPR, then that is a medical order that a medic who comes into a home in an emergency would follow. And so I think asking your healthcare providers to fill out a pulse form is a really, really important step to take in terms of really sort of figuring out how best to align the medical care that somebody gets with the medical care they would have wanted. So as dementia gets sort of worse, as it advances to its more severe stages, one of the things that does happen is that people can lose the ability to swallow, that they can become at high risk of choking on food that they swallow. And so it does sometimes come up of, so should somebody with very late stage dementia have a feeding tube, an artificial nutrition through a tube that is inserted directly into their stomach. And it can seem in some ways that would be a good thing as a way of more safely getting somebody calories. But this is actually something that has been studied very, very carefully by a number of very good researchers around the country over the last 10 or 20 years. And all of that research has been very, very clear that, contrary to what you might think, feeding tubes in late dementia actually do more harm than good. And as a result of these very, very carefully done research studies that show that, there's now extremely agreed consensus across all of the medical societies in the United States that all advise against tube feeding for advanced stage dementia. That these studies show that they do not make people more comfortable, that they don't even prolong life, and that they actually do cause harm by increasing the risk that people will aspirate some of the food that can come up from their stomach and go down into their windpipe and actually cause more pneumonia and more suffering. And so there's very, very clear guidance across the medical community that tube feedings do more harm than good in late stage dementia. And it's tricky, though, to sometimes figure out how to explain that to families, because it can be a really hard thing if you see your loved one sort of no longer able to safely get enough nutrition in. And so the way that I would discuss it with somebody is to say that that tube feeding just does not fix what is a slow dying process, that it's been shown to make people less comfortable, and that tube feeding for someone with advanced dementia really does cause more suffering. And so then the question has come up of, whether artificial nutrition like tube feeding should be in a dementia directive. So when I was first developing my dementia directive, I did for a time have a place where somebody could mark whether they would or they would not want artificial nutrition or a feeding tube if they had late stage dementia, but really came to the conclusion that it just doesn't make sense to ask people if they want an intervention which we know will shorten their life and worsen their quality of life. That yes, it's nice to give somebody an option to say that they wouldn't want that, but you can't really give somebody an option of saying that they wouldn't want that without also saying, well, if you don't say that, you're saying that you do want that. And it just doesn't make sense to ask to give people an option to say that they would want something that no good medical sort of provider would ever give to somebody, knowing that it could do them more, would likely do more than harm than good. But so really, we just need to improve the communication that when the time comes, rather than when the time comes to have the conversation about why that's not a good thing to do, rather than to try to elicit those preferences beforehand. So another really complicated thing that comes up as dementia progresses is assisted feeding. And so this is before tube feeding. So tube feeding comes up when somebody's dementia is so far advanced that they can't swallow, that it's becoming more and more risky for them to take any food by mouth. But really, quite a long way before that, in a dementia illness, people will often need assistance with feeding. So sort of helping to get the spoon to their mouth. And so there are a number of new advanced directives that specifically address this question about whether when somebody has advanced dementia and they're not able to feed themselves, would they or would they not want assistance with eating and drinking? And the two organizations that have put together really, really well done advanced directives that are specifically on this issue are End of Life Washington and End of Life Choices New York. And both organizations have somewhat tried to tailor their directive to be specific to the state that they're in. But I would say that either directive, either the End of Life Washington assisted feeding directive or the End of Life Choices New York assisted feeding directive, would be perfectly reasonable for anybody in any state in the United States to fill out. And so if you're interested in taking a look at these, I would go to both of those websites, both the End of Life Washington website and the End of Life Choices New York website, and compare the differences between the directives to see which one might fit your needs better, if this is something that you specifically wanted to express wishes about. I will say that there is some controversy with these directives in that there is arguments that people have. I'm not arguing this at all, but I'm just letting you know that what the argument that is out there is that there are some people who consider assistance with feeding to be just a part of kind of basic care, like sort of bathing somebody, as opposed to a medical thing that you can say in advance that you would decline or not want. And so I would say that that there is controversy about this, such that it is possible that in the coming years there will be legal challenge to assisted a advanced directive like this. I am very hopeful that these documents will be able to survive that legal challenge, because I personally believe that this is a medical care. Assisted feeding is medical care that somebody should be allowed to say in advance that they would decline and not want. But there is going to be, there is some controversy about this and some people who disagree with that view. And so if I were to sort of say what the take-home messages from my talk are, it really is to strongly encourage anybody over age 65 to think about filling out a dementia directive that you can get from the website dementiadirective.org for free. That as soon as possible, very, very early in the course of a dementia illness, it's so important to fill out a durable power of attorney form, a proxy document, to identify who the alternate to, say, your spouse would be. If your spouse wasn't available to make medical decisions on your behalf, who would you trust the most to honor your wishes? That a pulse form is incredibly valuable as dementia progresses, as really a medical order that you can fill out, say, with a primary care provider, to really lay out what the goals of medical care would be, and that there is a range of options to choose on a pulse form that do include comfort-oriented care only. And so this is what the goals of care are right now. So whereas a dementia directive, you're saying, in the future, if I had dementia or if I had this specific stage of dementia, this is what I would want. A pulse form is more, this is what the goals of my medical care are right now. And that as you do struggle through these incredibly hard decisions and conversations, that really coming back to the concept of imagining if your loved one who has advancing dementia could look down on themselves now, what would they say that they would want for themselves? And that is such an important thing to hang on to as a guiding light, to really help to feel like you're sort of doing right by them. And really important to know that these assisted eating directives are available, and I really do highly recommend them to anybody who does have strong wishes about whether they would or they would not want assistance with eating in a later stage of dementia. All right, and so that finishes the slides I've got, and it is 7:15, and so we've got plenty of time for questions. And I really want to thank you all for joining this evening, and really happy to talk about any questions that you might have.
And we have questions. So first of all, speaking of the pulse form, is this form used in all states?
Yeah, so that is such a really good question. That every state has its own version of the pulse form, and there has been, this is really a national movement, and every state has specific state laws that sort of govern their pulse form. But a really good thing that has happened in the last few years is that there has really been a movement to try to have more consistency among the states, to make sure that one state's pulse form looks very similar to another state's pulse form. And because if they are really consistent in that way, then they could be very, very portable even across state lines. And so, so right now there are subtle differences between one state's pulse form and another, but by and large, they are all very similar. And most states will honor a pulse form that was filled out in another state.
Thank you. Is a pulse the same as a DNR?
Great question. And so, and the quick answer is kind of yes. So in the way that a pulse form is it's a medical order, and one of the options on the form is DNR. And so if somebody were to sort of mark DNR and sign a pulse form, and then a medical provider were to co-sign the pulse form, then that is a DNR medical order that should be sort of durable and portable outside of a hospital. And so that if somebody did have a cardiac arrest outside of the hospital, then that medical order should be sufficient to say that that person should not get CPR, that the order would be do not resuscitate, which is what DNR stands for. That said, anytime somebody does go into a hospital, that is an order that needs to be verified and sort of redone. And so the pulse form is not is not guiding once somebody enters into a hospital, but it can be an incredibly valuable communication document, so that rather than starting the conversation from scratch as to what would somebody want to be DNR or not, if somebody goes to an emergency room carrying their bright green pulse form that says DNR on it, it can make that that process, once you arrive at an emergency room or hospital, that much easier to say, okay, I can see that another medical provider has had this conversation with you before, and that this is what the decision made, and is this still what your decision is? And it's just, you can say yes, and then that can be the end of what is could otherwise be sort of not necessarily a smooth conversation in a hospital.
And who fills out the pulse form?
And so it is filled out by a medical provider. And so it's an MD or a nurse practitioner or a physician assistant fills it out sort of in consultation with a patient or with their sort of healthcare agent. And then both, they have, so there's ideally a shared conversation about arriving at what the goals of the medical care should be. That would somebody want to be DNR? Would somebody want to be hooked up to a mechanical ventilator? And then marking that form, and then to make it a legal medical order, then it is signed by both the medical provider that you've had that conversation with and the patient or the patient's healthcare agent, if they don't have the ability to sign.
How important is it to name just one child as a power of attorney? This person says, I want to share this advice with estate planning attorneys.
Yeah,
and say they can consult with other kids.
Yes. And so, and I get this, I get asked that a lot, because on one, it depends on your kids. You know, I mean, I think if you have two kids and they are, you know, very, very much kind of the same thinking, and they are both sort of nearby to you, then there's nothing wrong with not identifying one of them. And it would just mean that they would both need to agree with any medical decision that was made. And so it's not a huge deal. You know, the other sort of side of a spectrum might be somebody who has, say, 5 or 6 kids, and maybe there is often a fair amount of disagreement among those kids. And maybe there is one of the 5 who you feel like very, very close to, and really feels like, and who you really feel like that person would have the most insight and understanding into sort of honoring your wishes. And if you've got one person among your kids who is like that, who you feel would be most capable and most insightful in terms of sort of serving that role for you, then I would highly recommend identifying that person among your other kids as your surrogate decision maker. And it's not to say that that person can't consult with and try to reach consensus from the other kids as well. But if there's one person who especially knows you best, and there's one person who especially lives nearby and would be very easily accessible in the case of an emergency, then there is a lot of value to identifying that person as your choice among your children as your durable power of attorney or healthcare agent.
I guess I would add to that Washington state law regarding surrogacy is complicated, in that if you don't have a durable power of attorney for healthcare, then you're going to end up having to have the entire family in agreement.
Yeah, it's not the entire family, but it would
well,
be
the 5
it
kids.
would be all of the
Yeah.
children.
Right, whichever.
So, yeah,
right.
if there's one, if you don't identify if you don't have a form, then the default is that it goes to all the kids as a group, and that they really do need to reach consensus, and that it only takes one kid to sort of put their foot down and sort of disagree, that can make decision making really difficult.
When do you recommend pulsed? In moderate or advanced dementia?
Yeah. So the pulse form is very much designed for anybody who has a very serious illness. And so, there's not much sense in filling one out when if one is very healthy and isn't suffering from a very serious illness. But if somebody has any serious illness, whether it is a cancer, a very like a metastatic cancer, or a severe emphysema, or very severe heart failure, or dementia, then filling out a pulse form is a really important thing to do because it gives you a chance to really have some intention to give guidance to what would happen in the future if something sort of catastrophic happened, like a heart attack or like a severe pneumonia, or something like that. And so the question of sort of when along the course of a dementia illness is the best time to fill it out, I personally feel like the sooner the better, because I mean it is important, because I mean everybody, there's not one, um, people have different uh, feelings about what they would want for themselves. And so not some people, when they have mild dementia, might say that, oh my goodness, I would really want comfort oriented care only in mild dementia. And so then filling out a pulse form that indicates that is a perfectly reasonable thing to say. Whereas another person might say, gee, I would consider the quality of my life to be so good with mild dementia, and even looking forward to sort of living with moderate dementia, that I might want life prolonging care at that point. And I might not want CPR if I had a cardiac arrest, because that might make me even more impaired if I were to survive that. But I might want to sort of go to the hospital and get life prolonging care, say in the form of IV antibiotics. And that's something that you could also indicate on a pulse form. And so I would say that a pulse form is appropriate at really any stage of dementia, but is for sure important as dementia starts to enter the moderate or severe stage, because that's really the point where most people really would want a shift away from life prolonging care towards care that's really focused more on just keeping somebody comfortable.
And here's a comment that kind of goes along with that. She says she was just thinking that if she were to look down at her when she was 45, she might have a different opinion than if she were looking down at 65 or even 75. Just thinking about how my values might change over time.
Absolutely. And that's why this the advanced care planning is not, it's not easy. It's not cookie cutter, it's not an algorithm. It is always going to be a complex sort of process of trying to do right by somebody, to honor their wishes, and to really figure out what do we think their wishes would be. It can be helpful to think about somebody, say, maybe not 30 years ago, but 5 years ago or 6 years ago, looking down on themselves in the state that they are in now. What might they say that, try to have a conversation, a pretend conversation with that person, to really try to channel sort of their wishes, to sort of honor them as the person who is different. They're different than they were, but they also, that still is their body. And so I think most people would still want, I mean, I personally would want my wishes honored rather than what somebody else sort of decided their wishes were, even if it's not, even if I am sort of in a different state. And I think most people would want that. They would want the focus on the autonomy of who that person was, as the wishes that should be honored.
And this person says 5 or 6 years makes sense. Younger, we were smart. Older, we are wise. I like it.
I agree.
So another comment is I'm a little confused about what a pulse form is. Is it something that gives medical personnel directions when the power of attorney is not available?
Not so much. It's let me explain it this way. So if there is ever a situation where a power of attorney was present, then that power of attorney really speaks for the patient and for the person. And so as the healthcare agent, if the question is, should we do CPR? And if the durable power of attorney says, yes, or says no, then that direction really would override whatever is in a pulse form. And so, but the value of a pulse form is kind of like the question asker is asking is, if the durable power of attorney isn't around, then that really does then the pulse form is a medical order that can sort of guide what the medical personnel would do in that situation. It was really initially imagined as really just to have on your refrigerator for if you call 911 and the medics arrive. By law, they are required, because they are not physicians themselves, and if they see somebody who, if they're called by 911 and they rush in and they find somebody whose heart has stopped, then legally they are required. They can't make a medical decision even with a durable power of attorney. They're telling them not to. They are in a little bit of legal limbo where they're somewhat required to provide aid to somebody. But if a pulse form is up on the fridge and it says DNR, then and it's signed by a physician, then the durable power of attorney really can sort of hold that form up and say, I'm so glad that you're here to offer emergency aid to my loved one, but I just want you to know that we do have a pulse form. So if there is cardiac arrest and it says do not resuscitate, it says DNR, please do not perform CPR on my loved one. Or if it says do not intubate, please do not put a breathing tube down, that these are our wishes and this is what has been signed by our doctor. And so in that way, it is a medical order that is sort of portable in somebody's home. But then I really find that the even greater value of a pulse form is when somebody goes to a new facility. So whether it's a new assisted living facility or whether it's a hospital, and the people who are accepting the person into the new place, whether it's a living facility or a hospital, they need to understand what conversations have happened before and what is the guiding order for right now. Is it full life belonging care, or is it comfort oriented care only, or is it something in between? And a pulse form can be just a very powerful communication tool signed by a medical provider and then signed by either the patient or the durable power of attorney surrogate health agent to say, here's the conversation that we had in the past, here's the decision that we made together, and yes, this is still what our wishes would be. And so in that way, it really can be a powerful communication tool in addition to actually a signed medical order.
Thanks. I just wanted to ask this so I don't forget, and somebody has asked if they can get a copy of this video. Hope has a YouTube channel, and normally we would have been live streaming this on Facebook, but Facebook was not being cooperative. So we will have it on our YouTube channel, and it will be available for anybody that wants to see it and share it. And someone says, thank you very much. I look forward to downloading your form for my patients and my parents. This was totally worth staying up past my bedtime. Thank you. And this is from Baltimore. Wow, awesome. And another thank you. And then I'll go to the Q&A. A little change. When do you get a parent into memory care? What are the signs?
Oof. Yeah. So
I
I will
didn't
tell
tell
you.
you there would be easy questions.
Yeah, and I will tell you, I mean, we are struggling with this so strongly with my mother-in-law right now, actually. So my wife's parents live in Chicago, and they are both really struggling with cognitive impairment, and are both very reluctant to leave their home, and so trying to figure out when to make that move is really one of the hardest decisions that there is to make, and there's just no easy answer. um, I will say that on so rather than answering the question, I will just sort of give you, the two sides of the coin, which, because there's really no way around just kind of trying to hold both sides of the coin in your head together and trying to do what's right for the person. On one hand, there is like just the autonomy issue, which is that by and large, people really strongly prefer to stay in their home. And it's just sort of, there are the relatively rare person who sort of ahead of time really identifies and recognizes that they may very well be better off at a memory facility, and when that time comes, sort of that's fine by them, and they'll happily sort of move. But most people just do not want to move, and so on one hand, it is important to, in the kind of, if that person could look down on themselves, what would they say that they would want us to do? And most of the time it is to stay in their home, probably past when it looks or feels best or safe. But I do feel like the honoring people's wishes often, and this is what I'm struggling with my mother-in-law and father-in-law right now terribly, is to honor their wishes up to a point. But then there comes to a point where it just isn't, it's not safe, or they don't have enough insight or understanding to realize that they are just not capable of providing the self-care that they need, and that it is, it costs often 3 times as much money to hire caregivers in your home as it does to be in a memory care facility. And most people just don't have that kind of money to spend. And so the other flip side of the coin is that memory care facilities have really come a long way by and large over the last 5 to 10 years, I would say. I mean, that there has been such a movement away, sort of, to make them less of a just kind of like a holding pen for people, and more a place where people really can have meaningful engagement and stimulation in a way that is actually often a better life than sitting in front of a TV by themselves in their home. And so I really do, I respect and honor both sides of that coin, and so there's just there's no easy answer to your question there, but there is just, I think, comes back to both what would somebody have wanted you to do, and then, but keeping in the back of your mind that at some point there is a limit to that, where you do need to provide a safe place for somebody, and that can actually now sometimes feel better because they are able to get stimulation and engagement to have a better quality of life often, than if they're living alone in their home.
I would say, from a support group, observing what people in our support groups will tell us, is that there are times when they have actually been told by a physician that they need to place their loved one for their own health.
Yeah, yeah, yeah.
So,
I mean, this is the hardest disease of all, and it is. I really do think of my job as a primary care doctor is not just taking care of my patients who have dementia, but also taking care of the people who are taking care of my patients with dementia, because the amount of of psychological stress and pain that can happen taking care of somebody with dementia can be overwhelming. And it's really important to reach out and get help when you need it. And sometimes that help is a memory care facility.
there's a question about facilities following the Dementia Directive. How open are they to following that directive?
Yeah. So the Dementia Directive is relatively not controversial at all. I think, hopefully, for most places that so like where there are some very strong end of life wishes directives that people can fill out, like the assisted eating question. That there are going to be some facilities that will have a lot of trouble with a directive like that. Whereas a dementia directive is really a guide to filling out a PULSE form when that stage of dementia is reached. And I would say that there has, in the same way that I think that a lot of living facilities have become more enlightened about providing better environments for people with dementia than used to exist, I think they also are becoming more and more understanding that for many of the people, for many of their clients who live in those facilities, that the goals for their medical care may very well be a shift towards comfort-oriented care rather than life-prolonging care. And so, generally speaking, these facilities ought to be, and I think increasingly are, very respectful and honoring of a dementia directive that might lead somebody to fill out a PULSE form, which might say comfort-focused care only and no life-prolonging care. But there's also, I mean, this is a very cultural, it's a cultural shift that's happening in our society, and it's not happening at equal rates in every part of the US. It definitely varies a lot in other countries around the world. And so I'm somewhat speaking from the sort of Pacific Northwest, especially kind of west of the Cascades, in terms of what these social views are. But I am definitely aware of, I think that things are a little bit different on the East Coast, say, than they are on the West Coast. And so I can't speak in any knowledgeable way throughout the US, but I would say that at least the facilities that I'm aware of that are in the Seattle area, and generally in Washington State and probably in Oregon as well, that facilities are generally pretty respectful about honoring the choices that somebody might have indicated in a dementia directive.
So I have a comment for you. People must be so relieved to have this document as a place to start this conversation.
Yeah, and I really do think of it in that way, that this is a structured way to sort of have the conversation. These are not easy conversations to have. People really, it's a rare person that wants to have this conversation, and just even knowing where to begin or how to have it is very, very hard. And so the conversation project in Boston, their website has a really good guide for a conversation. It's designed more to facilitate a conversation with a family who's caring for somebody who already has quite advanced dementia. And so this is, I think of as a conversation guide for people before they develop cognitive impairment, to help feel more secure that they've expressed their wishes and had them documented.
I'll send the link out to the Conversation Project as well. Can we find information about your research and the U of W research? Someone asked.
Yeah, and so there, if it's specifically research about developing treatments for dementia, then I would direct you to the website for the University of Washington Alzheimer's Disease Research Center. So they have a website that has a phone number that you can contact to find out about what studies might be going on in terms of developing treatments for dementia, and to see whether there might be any studies like that you or your loved one might qualify for. The research that I'm doing is really specific to helping to develop better ways for primary care doctors like myself to identify dementia earlier in a primary care clinic and then help patients and families navigate through that disease. And if you're interested in supporting work like that, then feel free to email me. My email address is on the website. And I will say that most of the work that I have done over the last 6 or 7 years has been funded by donors, and so I'm very appreciative for anybody who is interested in helping to support my work.
Awesome. What tools do you like for educating patients about CPR, ventilators, et cetera, and the outcomes?
Yeah, that's a hard question, and I don't have a specific tool. I mean, I specifically have had that conversation so many times with people that I'm able to just kind of have it without a tool. But I really, especially for talking to people or families when dementia is the disease that's at the center, really talking about the idea that the benefits of CPR or a ventilator, mechanical ventilation, for somebody who has dementia, the benefit is much, much less. And the risks of harm are much, much greater because of how much somebody's brain is already in an impaired state, such that any additional sort of damage that brain might get, sort of living through a catastrophic cardiac arrest or a severe pneumonia leading to a respiratory arrest, is so much more likely to cause more damage to their brain and leave them in a much more impaired state than they were before that event happened, that the value of CPR, the value of mechanical ventilation, going to an ICU is just much, much less for somebody with dementia, and the risks of suffering and harm are much greater.
Respecting Choices out of La Crosse, Wisconsin has some little infographic things that are a half page. I don't know if you've seen them.
Yeah, very good.
Yeah, we use them for quite a while with our education and found them really useful.
Yeah, they're doing great work there.
Yeah. So how do you suggest approaching this directive with someone that's in denial about having dementia?
Yeah, so that's really hard. And I mean, I've talked about how much we're struggling with my in-laws. So my wife's parents both have cognitive impairment and are really in a hard and complicated place. My father, so not my in-laws, but my father, it took him years and years to finally sort of sit down and have this conversation with me with a dementia directive in front of us. And he, for years, was really reluctant to not, I mean, because he doesn't have cognitive impairment, but he was reluctant to just have this conversation. He felt like it was giving up control by filling a document like this out. And it was kind of a breakthrough moment that we had one day where he realized that actually by filling this document out, he wasn't sort of giving up control in any way. He was actually having more control over his future by filling this form out. And so, I mean, so that you know, it was a many-year process of getting my dad to that point. So I definitely don't mean to say that it's an easy thing to do, but I would say that if you really do wish you knew what somebody's wishes were, and you wish that they would fill a document like this out, but they seem reluctant to do so, really focusing on the idea that this is a very common, that dementia is a very common thing that affects 1 out of 3 people if they live long enough. And so the odds that any of us may someday face a dementia illness is pretty high. And that once you get there, you won't be able to express your wishes or make decisions because you're going to have trouble understanding what those decisions are. And so this is your chance to give some guidance, to share what your preferences and values are, so that we can do a better job of honoring those preferences and values later.
My father has early stage dementia. Do you think it's too late to have a conversation about assisted feeding?
Maybe. There's no yes or no answer to that, because it depends a lot on the person and depends a lot on sort of where they are even at in the stage of early stage. But again, my experience is that even in the very earliest stages of Alzheimer's disease, it is really hard for people to really imagine future states of themselves. And at first I thought it was just that people were having trouble just with the psychology of it, that they were so, the fear of facing dementia was so great that that's what sort of prevented them from really understanding and having a conversation about it. But then, like, after years and years of trying to have conversations like this with people, I have really come to think much more that rather than an emotional block, it really is it's almost a physiological block. It's not that they don't want to, but that they can't. They're unable to. That we take it so for granted that we can imagine the future state of ourselves, and we lose sight of the fact that that's actually a really complex thing that our brain is doing. And so giving people, as even if we try to create these very simple what if scenarios for the future, that's actually asking that's a pretty high level cognitive thing for our brain to be doing, that is actually lost early for many people in a dementia illness. And so they still may be perfectly able to say who they would want their durable power of attorney to be. So they may be fully able to fill out a healthcare agent DPOA form and say who the alternates on that form would be. But that's just a much easier sort of question to ask than to ask a question of somebody like, in the future, if you're in this very advanced state and you're not able to eat, would you want help with eating? It's a complex question to pose to somebody. And if they are suffering from cognitive impairment, it might be really, really hard for them to answer.
Do you have preferred phrases or ways to lead into these conversations?
I think I've probably shared a bunch of them with you already this evening. I think that the important ones are that, this is a common thing that happens, and that it's really hard when we don't know what somebody would have wanted, and we really want to sort of do best by them and do right by them. We want to honor them. And so it really can be important to think about these hard things and these sort of unpleasant scenarios for the future as a way of getting better care that more closely aligns with what somebody would want, which is really better care.
Are you saying that even with a pulse form, when coming to the hospital will initiate a new one? Well, what
Right.
if you can't speak or no one is there to speak for you?
Yeah. So, legally, a hospital does not, the way that each state has legally set up the idea of a pulse form is that that is the medical order that is in play when somebody is sort of in their home. But that the medical orders that guide what happens in a hospital need to be sort of medically ordered by the doctors who are there in that hospital. And so the pulse form can be a very, very important guide to informing the physician in the hospital there as to whether to write an order for full code, or write an order for do not resuscitate, or write an order for do not intubate. But that order does need to be legally written by the physician that's there in the hospital. And if somebody arrives at the hospital with a pulse form, one would hope that most medical providers would use that to inform them as to what medical orders to write there in the hospital. And it can be hard if the person is not able to speak, and that's where, if somebody's not able to speak, then they do sort of go looking to find out who is the durable power of attorney, who is that healthcare agent, who can confirm that the pulse form that was filled out in the past is still an accurate reflection of what somebody would want then and there.
Well, we're almost done. I have lots of thank yous. The lady that talked about her mom who's in denial says having more control is a great way to frame that conversation. Thank you so much. And then somebody is asking about your thoughts about the use of the Mocha Scale. And I guess I would ask if you have a favorite, if what you use in your practice.
Yeah.
If you use them, I'm sure you do.
Yeah. So the Mocha test is the Montreal Cognitive Assessment Test, and it's probably the test that has been studied the best to show that it does give an accurate reflection of the tests that can be done in sort of 10 or 15 minutes. There are tests the tests that you can give somebody an hour or two of tests that are better than a Mocha test for sure. But if you want a test that is shorter and can be done in 10 or 15 minutes, that has good predictive value for predicting how somebody would score on the much, much longer tests, then the Mocha test is probably the one that has been studied and shown to be the best in terms of helping to diagnose cognitive impairment.
Thanks. I see a Dr. Gaster, this was really useful information for me and my family. Thank you. And another thank you from Philadelphia. Now let's see. Somebody just makes a comment. I wonder if seeing what's happening with your in-laws has helped your dad decide to deal with it.
Yeah, so right. I mean, the sequence of that was that the conversation with my dad was actually finally happened 2 or 3 years ago, before my in-laws really sort of started having a hard time. And I think my in-laws have just suffered so much from the pandemic. That the isolation of the last year, like so many people with dementia, has just been devastating. Because people often ask me, what is the most important thing that I can do to keep my brain healthy? And the number one thing that somebody can do to keep their brain healthy is to stay engaged and social. That the more that somebody is interacting with friends and having conversations, the stronger and healthier that their brain will be. And so the isolation and lockdown of this past year has been absolutely devastating for not just the people with dementia who have died of COVID, but many, many more people than that who have suffered from the lack of social and engagement that is just such an important thing to keep our minds going. And so it is looking forward so much for this thing being past us, and the COVID vaccine is the number one ticket that we have to getting past it, to allowing people to get together safely. And I think one of the big giant wins that has happened already with the pandemic is what a good job we generally have been doing of getting people over age 75 vaccinated. And so that the number of people with COVID in the hospital who are over age 75 has just plummeted. And the number of people who are dying over age 75 of COVID has just plummeted. And it's really vaccination that has made that difference.
Awesome. Thank you from San Diego.
Wow, I thought this was a Vancouver, Washington support group.
Well, we do get out there.
All right, that's great. That's great.
All right, thank you so much. You've been so helpful. We really appreciate you doing this for us.
It really is my pleasure, and I hope you all have a good evening.
You too. Thank you. And everyone that's still on, I will send you out all of the information that we talked about.